All right, Ben, we recently talked about anxiety disorders more broadly. I want to hone in on a more specific yet ironically general type of that, which
Right.
is generalized anxiety disorder. You had told me earlier that it's probably the one that we see the most, largely because it exists pretty in prevalent fashion, but also because oftentimes providers are lazy and they just sort of lump people into that. So, in your view, what is generalized anxiety disorder?
So, I've shared some of this before, and it'll sound a little bit repetitive, but the two schools of thought. Number one is generalized anxiety disorder is, a fear of something, someone, in the future. Typically, it's kind of like the visual of what's around the corner. I don't know. I don't want to go there. I don't want to do that. I want to avoid. I don't want to deal with, the present future. And so people then isolate, and they don't do the things that they need to do in their activities of daily living, right? And in their life. So generalized anxiety disorder is all the things we've talked about: the intrusive thoughts, the physical pain, just your brain running away with ideas that are probably not true. But the other factor that I want to share with you is that we don't know what we don't know, and generalized anxiety disorder it's a catch-all. So it's a catch-all for the experts and the really smart guys that put together the DSM, the Diagnostical Statistical Manual for, it's the handbook for behavioral health clinicians. And they say generalized anxiety disorder because they don't know, right? It's so broad that we know people have fear. We know people are not functioning. And so they have this diagnosis. So at least we get the person into the right bucket. Mm-hmm. And then from there, we can deal with, okay, is it a medication issue? Is it a psychosis issue? Is it just completely out of their minds? Is it a behavioral issue? Is it a substance abuse induced issue? We don't know. And so that's the other piece of it that I want to share with you, because just because you're diagnosed with generalized anxiety disorder, it doesn't mean you're crazy. And it may be circumstantial.
Sure.
Right?
Sure. And I think that's the difference between someone that might need a level of care like what we offer, PHP, IOP, versus things happen in life and people get anxious, and it's part of the human condition. So the question really is that you're honing in on: is it debilitating? Is it chronic? And what is the source? Is it a chemical thing going on? Is it a outlook on the world that's not going to be fixed anytime soon, even when this particular circumstance starts to sort of dwindle?
Yeah.
And so, you're looking to treat somebody, and I know it's a complex question to answer because it depends on a lot of different things.
Right.
But like, what's your go-to, at least framework for thinking about how you're going to formulate a treatment plan?
So my go-to is life circumstances. What's their living condition? That's the first thing. The next thing is medication compliance, success, resistance. That's the second thing. The third thing I look to the patient. What have you done in your recent past that has been successful? You were less anxious. You were more functional. You completed tasks. What were those circumstances? Who were you with? What did you do? Also, are you having fun? Or what are you doing with your life? But I want to go back to the environmental thing, because I think with generalized anxiety disorder, this is critical. I'm going to give you an example. So we had a patient here who had OCD, severe OCD, which of course, is a form of anxiety, tremendous anxiety, very bright girl, master's degree and all of that stuff, but non-functional. Why? Because her parents weren't focused on her anxiety. They were focused on she should lose weight. And so that became an anxiety provoking item where she was doing all these things, but why aren't you losing weight?
Mm.
Why aren't you focused on this? This is good, but this would be better. And that's a theme, a communication theme that families do to themselves.
Mm.
They focus on the wrong things. They enable instead of love. They are more interested in making themselves feel better at times than making their loved one get better at times. And maybe what I'm saying right now might upset some families, but it's also very critical for them to understand. There's no, like, it's not like I'm sitting here upset at families. Like, it's an illness, so it impacts everybody around them.
Sure.
And we address that.
Yeah.
We address that.
Yeah, it's great watching you, from where I sit, hone in on the variables that are moving the needle in the wrong direction, whether it's the family dynamic, that's a very specific scenario, whether it's a chemical imbalance, whether it's, it can be so many different things. And I know that's the challenge of behavioral health. We can't be married to any one modality, any one, type of path to getting better, because if we do that, then we narrow the scope of our view, and we may miss the boat.
We're going to miss. And I play percentages with an illness. Illnesses, by their very nature, they're not curable, right? But what we can do is we can arrest the process, we can manage symptoms, and we can educate the patient and the family to regulate feelings and emotions and behaviors. And that's the essence of treatment. Anybody that tells you anything else is selling you something.
Yeah. Appreciate that.
Yeah.
Thank you, Ben.